Okay, so the last part of Learning Plan 6, then, we're looking at Chapter 21 in Varkarolis, Impulse Control Disorders. So, oppositional defiant disorder. So, we have to think about risk factors, genetic component, family history of mental illness, neurobiological causes, and certainly environment when we're thinking about all the different types of risk factors for having this disorder. So, first of all, I want to start out by saying that oppositional defiant disorder sounds serious. Of course, it is. However, we have to remember that kids that have this disorder are usually they're very difficult, but they are not dangerous. So they're not doing things that are likely to cause harm to themselves or others or to even get in trouble with the law. So very different between this disorder and conduct disorder. So when we get to conduct disorder, again, I'm going to point out the differences between the two because it really is essential for the nurse to understand the difference between the two. So with oppositional defiant, while the child might be difficult to manage and deal with, and they have lots of interpersonal difficulties that affect their relationships with not only with peers, but with family members and any authority figure, but they are not, usually, well, they would not be with this diagnosis then if they were doing things that were totally against social norms, things that we would think of in terms of being, again, dangerous to themselves or dangerous to other people, and, using and abusing people and fighting and hurting people, setting fires. Conduct disorder is really the much more serious disorder of the two. You might also be thinking, as you're reading the name of this diagnosis, that, well, gosh, a lot of kids have problems with behavior, and a certain amount of being oppositional or kind of contrary or defiant is actually even normal for older children and early adolescents. So lots of times kids are struggling with developmental tasks of trying to be an individual, they're individuating away from their parents and trying to set themselves apart. They're trying to strike out and be a little bit more independent, all of which are really good things, but it does become a disorder when it kind of goes beyond the normal amount of oppositional kind of behavior you would expect from a child, because it really does. It just, as the book says, it exceeds the boundaries of what is really socially acceptable, and it impacts their anger. They're more angry and irritable, have more irritability, and they're more argumentative and defiance. And again, in order to be a diagnosis, it really has to be seen over a span of time. It's not just they have a day or two here or there where they're particularly, oppositional or defiant about something. So, normal adolescents can again be going through some of these issues. So we wouldn't want to give them a diagnosis if they're just having occasional occasional problems related to perhaps to peer pressure, and maybe wanting to give in to peer pressure to go to a certain party or do something that kind of pushes the limits of what they know their parents are allowing them to do, because adolescents are definitely into testing behaviors. So again, what sets this apart as a diagnosis, we're looking usually for a consistent pattern of behavior, not just an occasional pattern of behavior. Some kids can actually outgrow this disorder, but even without treatment, but many do go on and experience difficulties in their social, work, academic, all of those types of situations are going to be affected. Okay, so let's delve into some risk factors a little bit. I also noticed that I want to just mention quick that up at the top, the title of the slide, it says Oppositional Defiant Disorder Continued. I think that's because probably at the last minute I switched the order of, I think it's this slide and the next slide, and I guess I just forgot to take off the continued. It just made more sense to go through this slide than the next slide that talks about this disorder. So in case you're wondering, continued, anyways, so risk factors, really interesting. It's not on the PowerPoint, but in the book they talk on page 394 about resting heart rates in children, and sometimes a low resting heart rate is actually positively correlated with increased aggression. So really very interesting thing that we should be doing more studies about. So genetics, again, most of the time there is a genetic component, family history of mental illness, and this disorder tends to manifest itself kind of at a young age, usually typically around 8 years old or so, and that research has shown that about 40 to 60% of people with that have antisocial behaviors and those aggressive behaviors have a genetic basis, so a very strong family history component. Numerous neurobiological causes. Several neurobiological causes have been identified. The amounts of gray matter and also structural abnormalities of the brain, along with neurotransmitter differences with serotonin, norepinephrine, and dopamine systems. So again, if you kind of look at that and think about some of the mood and psychotic disorders, so there's lots of similarities. So again, we always have to think about when we have such similarities with brain structure and function and neurotransmitters that there's many times there are crossovers of symptoms and comorbidities that we have to kind of think about. So we also need to look at the family. So family dysfunction can certainly play a role, and even some other aspects of environment. So the next two slides are going to show some cartoons that we'll talk about that kind of relate to environment, but it can also include just in general family distress, inadequate parenting, problems with attachment, so the child is not able to attach to the parent. And again, we usually think about situations of abuse or neglect, conflict in the marriage. Children from large and impoverished families are also at higher risk for those disorders. A couple of other family dysfunctional patterns that have been correlated are neighborhood violence, lack of structure within the home, and if the child is subjected to harsh criticism within their family. As for treatment approaches, maybe by now you're also seeing kind of a pattern in what treatment approaches that we're using for kids, psychosocial interventions and psychobiological interventions. So usually the psychosocial interventions are really aimed for helping the child and the family to manage their anger, improve their problem solving, techniques to reduce their impulsivity, improve their social interactions, all types of things like that. So it can be individual, group therapy, specific approaches about anger management. So all those things might be really helpful for the parents and also for the child. As for the psychobiological interventions, many times we're thinking about medications. There really is no medication that is approved specifically for the treatment of oppositional defiant disorder, but just because of the similarities and crossovers with some of the other disorders that can be comorbid, you can, and just if you think about the medications that work on those neurotransmitters, so some of those medications that are actually for other disorders may be helpful in treating oppositional defiant disorder. So even a mood stabilizer like Depakote can reduce aggressive behavior, and it looks like sometimes some of the medications that are even used for ADHD can also be very helpful for this type of disorder. Okay, so this comic is a little girl is saying a new study says television can lead to aggressive behavior by children and teenagers. So again, let's think about an environmental effect. And it looks like the dad is sitting there with a bag of chips and saying, "Buzz off, Four Eyes, I'm watching the Dukes." So very kind of a, really difficult environment for the child, not very good parental support. And so that's just an example of an environmental issue. So if you have criticism and possibly even violence in the home and in the family, that's certainly an environmental problem that can affect children. And when we think about environment, we can also think about what's on television. And thinking about Tom and Jerry. And Tom and Jerry's been around for a long time. And certainly cartoons and certain types of television shows have violent episodes. And that is also considered an environmental issue that can definitely affect behavior in children. So back to oppositional defiant disorder again. So again, angry and irritable mood, defiant and vindictive behavior. They have social difficulties, conflict with authority figures, especially think about parents, teachers, people like that that have a regular role in their life. And consequently, they may have some academic problems. The next disorder is intermittent explosive disorder. And I used to see kids with this when I worked in Rochester. We had quite a few kids come in with intermittent explosive disorder, and they really had a great deal of difficulty, especially in school and in their family situations. So they have an inability to control their aggressive impulses. The common pattern is to go from rage to remorse. So they act out and do something in a huge um, amount with a huge amount of rage, and then they quickly go into a state of remorse. They're really truly sorry for their behavior. And so their behaviors can really lead to problems with interpersonal relationships, occupational difficulties, and then even possible criminal difficulties. Because if they get to the point where some of their behaviors are, destroying property or things like that, then they can be held legally responsible for some of those actions. They give a great example in your book about some of that kind of explosive, aggressive behavior. First of all, they're saying that anything can trigger that aggressive reaction. They can't find their favorite video game. It might be something as simple as that. But I really like the example that they give about following a slow driver, and that possibly that response might be then, they just get this explosive anger that hits them and act aggressively. So they may hit the gas dangerously past the person on the shoulder of the road, and then they may immediately kind of feel like a sense of like, aha, I passed them, give them a negative hand signal, and then afterwards they're going to kind of feel regret and say something like, wow, I just risked my life to pass an 80-year-old man to get to a party that will go on for hours. I have to stop doing this. So sometimes afterwards they really do get that remorse and kind of think about their behavior a little bit, but it just comes on sometimes just very, very quickly, and hence the name intermittent explosive disorder. So comorbidities, depression, anxiety, and substance use disorders. And again, we always have to think about substance abuse as a possible way for the person to self-medicate against those feelings of tension and aggression and anxiety. They may also have antisocial and borderline personality disorders. Some risk factors, again, go right back directly to the brain. So loss of neurons in both the amygdala and hippocampus. So there are also abnormalities in serotonin in the limbic area of the brain, and all those have been linked with people that have this diagnosis. So abnormal changes in the brain. Conflict or violence in the family of origin. So being exposed to violence at an early age actually does change the brain, and it's also very common for those families to have a history of addiction and substance abuse. So different types of very serious family issues. So those environmental risk factors of the difficult family situations and situations as serious as abuse and neglect really can put the child at high risk for suicide. So we always need to be assessing for that as nurses. Treatment approaches, usually psychosocial and pharmacological. So a combination of medication and therapy usually is the recommended approach, as with most of the rest of these disorders. And SSRIs are used at times. So Prozac, Paxil, and those are used to try to mediate some of the difficulties that these patients have with their neurotransmitters. Antipsychotics might be used just because they have a very calming effect. But again, depending on the age of the child, we have to always be looking for side effects to some of those antipsychotics. We certainly don't want the kids to be developing tardive dyskinesia. Conduct disorder. Now, this is the disorder that is really the most serious out of all that we've talked about. I'm just thinking now it's too bad I didn't highlight it in red so that it really stands out, because these kids really have behavior that is outside of social norms. It is unusually, it says here usually, but really above and beyond abnormally aggressive behavior. The rights of others are violated, and societal norms or rules are disregarded, and they have a lack of remorse for their behavior. So I wonder if, as you're listening to this, if you're thinking of when we did the personality disorders learning plan, if you're thinking this sounds kind of similar to one of the personality disorders that we talked about. And it actually is very similar to antisocial personality. So if kids have conduct disorder and they don't receive any treatment, it is very likely that as an adult, they are going to develop antisocial personality. This is pretty much a precursor to antisocial personality disorder. And if you remember that disorder, again, there's no remorse, and people are doing things like as serious as killing people, conning them out of money, and just absolutely having no remorse at all. They are totally interested in their own needs and trying to get their own needs met, and they don't care how much they walk on other people or use them or abuse them to get what they want. So this is like the childhood version. So again, if we don't get these kids into treatment, they are very likely to end up as having an antisocial personality as an adult. And the consequence to that usually is that if they're doing things that are outside of what is lawful, they are going to end up in the jail system. So on here, the slide, it says academic failure, school suspensions, and dropout. The kids are going to drop out from school at times because perhaps they just aren't interested anymore, or even they are kicked out of school because of their behavior. Juvenile delinquency, drug and alcohol abuse, and juvenile court involvement. So this really is the most serious of the disorders. Two other associated problems with conduct disorder seem to be pyromania and kleptomania. So setting fires and stealing things. So again, those are very serious behaviors that have consequences for the safety of that person and the safety of other people around them. And of course, legal complications. So case study, Jeff, 15, is described by his parents as rebellious to the point where he's really impossible to control no matter what approach we try. He's been like this from the time he was very small. We are at our wits' end. In fact, Jeff's parents are not the only ones concerned. His history shows that from the beginning, in kindergarten even, teachers and authorities have documented Jeff as spiteful, vindictive, and physically aggressive. So truly, the physically aggressive part sets him aside and really makes you think about conduct disorder. Just being spiteful and vindictive in and of itself, and maybe just difficult to deal with, and having problems with authority, talking back to teachers, things like that, might be more, you might think, that's really not really conduct disorder. That sounds more like oppositional defiant disorder. But when they become physically aggressive, then we're getting into behaviors that, again, are outside the realm of being socially acceptable. And again, they have legal consequences. So treatment approaches, psychosocial interventions, and pharmacological treatment. So for our treatment approaches, when we're thinking about psychosocial interventions, we really want to try to target their specific behaviors. If they have difficulties with anger, if they have difficulties with their relationships with their parents, that might be something to really focus on, and actually involving the parent in the therapy could also be very helpful. So it's pharmacological treatment. So again, usually combination of both is what's recommended. So there are 5 classes of medications used for this disorder, and antidepressants, mood stabilizers, stimulants, antipsychotics, anticonvulsants, and adrenergic medications all show that they can be somewhat helpful. Abilify and Risperdal are 2 second-generation antipsychotics that also have some proven efficacy in diminishing the aggression with kids with conduct disorder. Case study, audience response question. Jeff was diagnosed with conduct disorders, taken to the principal's office after assaulting and injuring another student. Which comment is this adolescent most likely to make? I just lost my temper, but it will not happen again. I'm sorry and embarrassed that this happened. I failed my math test and guess I was just having a bad day. So what if that kid was hurt? I should have beaten him more. So I'm hoping that you picked D, that would be most typical of somebody with a conduct disorder. So again, just a comic strip, kind of a representation. So the child with this conduct disorder is likely to be the one to initiate the physical aggression. So they're not just fighting back and defending themselves, they are initiating the physical altercation with the other child. So applying the nursing process, of course, we're always assessing for suicide risk. They are at risk to hurt other people, but they are also at risk to hurt themselves. We have to really look very carefully at the level of distress in the child. We have to look at predictors of suicide risk. If they've had any past thoughts, threats, or attempts at suicide, if they have a plan, we have to look at the lethality of the plan, accessibility of the methods, feelings of hopelessness, changes in level of energy, circumstances, motivation, views about suicide and death. If they've had a family member or friend either attempt or complete suicide, that can certainly have a negative outcome on the child. And if they do have a co-occurring depression or a mood disorder. And again, that history of impulsivity, poor judgment, decreased decision making, all can lead us to having a very high suicide risk. For assessment tools on page 400, if you look at the tools that they have here, there's one for oppositional defiant disorder and another for conduct disorder. So basically, it's on a scale of never, occasionally, often, or very often, and the different behaviors are really outlined very specifically as far as what we're looking for. So I think if you look there too, that will help you to really understand the difference between the two disorders. So tools like this can actually be very helpful just to look at the impact of the different symptoms on that person's life. Self-assessment, I'm going to defer that for a minute. We always are doing a self-assessment because we may have some very strong feelings attached with working with kids like this. I have another whole slide on that, so I'm going to wait a minute on that and just point you to another table on page 401 down at the bottom, purple table, signs and symptoms, nursing diagnosis, and outcomes for impulse control disorders. So some of the diagnoses are risk for suicide, risk for other directed violence, like we just talked about, defensive coping, and impaired parenting. So some of the outcomes are related to having that person express their feelings verbally, refrain from suicide attempts, plan for the future, controlling their impulses, identify social support, identifies ineffective coping, and of course we want them to learn new coping strategies, and that parents or caregivers are participating in that therapeutic program and learning appropriate parenting skills. So those are some diagnoses and some outcomes. Some other diagnoses, again, risk for suicide, risk for other directed violence, defensive coping, impaired parenting. So just to kind of put those separately out there for you. And then that's self-assessment. So some common negative attitudes that we might have is a belief that the patient is choosing not to get better, and a belief that concern for safety might be exaggerated. So concerns for safety, especially when we're thinking of suicidal and homicidal ideation, really aren't exaggerated. If the child is saying, or adolescent is saying things like they have feelings of hurting themselves or others, we really have to take those very seriously. We can't just say, they're just trying to get attention, or they're just trying to get me to to respond to them or something. We really have to take all of those very, very seriously. We ever feel that we can't take care of somebody adequately because of our own strong personal thoughts or feelings or beliefs, values, then it's always good to get some supervision, some clinical supervision from somebody who you work with. Preferably a master's degree nurse would be the best person. A supervisor could also be very helpful. And we just have to really remember that we're all abiding by the nurses' ethical and professional responsibility codes that we have to provide equal care for all people, display empathy for patients who have different diagnoses and behaviors, even if some of the behaviors are objectionable to us. So that's a really difficult thing. That would be another really good topic for post conference. I'm going to have to write all these down and make sure that we talk about these when we're in clinical, because that really does come into play quite a bit when people have really difficult behaviors that are just um, really that things that we have a great deal of personal feelings about, kind of hard to take care of that person. So trying to have that empathy, which means that we are trying to walk in their shoes and understand what they're experiencing. And then we do have to consider the patient's environment of origin and history of constant negative responses. So, family history, environment, all of those things, brain changes, neurotransmitters, if we kind of look at it a little bit more objectively that way, it might be easier to take care of that person. So again, the psychosocial pharmacologic interventions, health teaching and health promotion to the patient and to the family, teamwork and safety. When we have a patient like this on the mental health unit, again, we need to all have information and understand what's going on with that patient, because we all want to have our eyes and ears opened and make sure that that patient does not engage in suicidal or homicidal behavior. Again, seclusion and restraint would be the last possible interventions. We really want to provide care, especially for kids and adolescents, but really for everyone, in the least restrictive environment and least restrictive manner. And we're always going to be evaluating our care so that we see if our plan of care is effective or not. And then we would always make modifications if things aren't working the way we thought they would. And now, just a little slide on depression in childhood. We kind of covered it a little bit when we talked about Learning Plan 3, but it is a competency for this learning plan. So just a quick summary, and then just also to realize with all of these disorders that we just talked about, depression is certainly a comorbidity that is very common and something we always need to be looking at. So I'm kind of taking some of this information from chapter 14, which is depressive disorders, because these childhood chapters really don't cover childhood depression any longer. So, page 245, it looks like I'm kind of down at the bottom, kind of looking at that area down there. So, we have to really realize that depression in childhood is really very much under-recognized, mostly because the symptoms are just so variable by age and circumstance. So the rate is much higher in children than adults. So more children are depressed, we believe, than adults. So that is something that we really do have to pay attention to. Even infants can be depressed. It is definitely easier to identify in adolescence, but I'm wondering if you can think of any reason why a baby, an infant, might be depressed. So I'm hoping you come up with that probably that child is going through neglect or abuse or both. So neglect, certainly, if you go back to your developmental theories and think about Erickson and just think about bonding and how the baby is really supposed to be developing trust. And how do you develop trust when somebody is ignoring your needs and not meeting any of your needs? So you not only not develop trust at that developmental stage, you actually can become depressed. So a baby is going to show signs of depression by just being very passive, not feeding or eating very well. They could have a little bit of the sleep disturbances, but really it relates mostly to their behavior as far as their feeding and their just like their interest in things around them. They're going to just be more like passive and kind of withdrawn almost if they are depressed. So we really do have to even think about babies as possibly being depressed. Children, adolescents, any age can experience depression. So there are some differences, such as the mood, instead of being more maybe sad or depressed, the mood might come across as being more irritable. And instead of usually when we think of adults with depression, we think about failure to make expected weight, or we think about with adults weight loss or sometimes weight gain. But with children, because they're growing, they are supposed to be gaining weight at a certain rate. And so if they have a failure to make that expected weight gain, that would be a specific symptom for childhood depression. School performance decline. So all of a sudden they're just not doing very well in school. They were an A student and now all of a sudden they're failing a bunch of courses. Their social participation declines. They're not hanging out with their friends anymore. They're not, maybe they were on the swim team in high school and they just drop off of the swim team and they're not even doing it anymore, even though that's something that they used to like. So some of that anhedonia, that lack of pleasure in activities, we can certainly see that. They're not hanging out with friends, going to parties, doing things that usual kids or teenagers do. Their ADLs are going to take a decline. They're not going to be as concerned about their appearance, and they're not going to be maybe even combing their hair, brushing their teeth, just putting on makeup, paying attention to their grooming. So that's going to be at a decline. And certainly depression in childhood and in any of these illnesses certainly puts them at higher risk for suicide. So if we don't pick up on and assess depression in childhood, then these kids have a risk, not only a risk for suicide, but also we're kind of setting the stage for lifelong periods of them having depression. Okay, so with that, this is the end of Learning Plan 6, and I will see you for Learning Plan 7.